Thank you very much. I enjoy coming back here for 10 years now, same as Karina, and from the first meeting. And something that I want to mention is when you were talking about the knee surgeon guidelines, I'm speaking next Thursday about the knee denervation, so I'll transmit your message. Please. I'll let them know. So see, these are some faculty disclosures, and some of the learning objectives. We're going to discuss who are the candidates, and I think Karina just covered this so nicely. I don't have to go too much back to it, but also providing some appropriate denervation technique and talk about the outcomes, at least data that we have right now. So when it comes to knee denervation using radiofrequency ablation, in any practice, we use 2 blocks with greater than 50% of the pain relief, which is a relatively high standard, to go on and have the radiofrequency ablation completed. Our denervation process is based on mainly this beautiful study with a very wide frequency of nerve positioning. I'm not going to go back. You just heard about it. But I really want to warn you about the wide location of these wide frequency. If you look at the 15 cadavers and this beautiful dissection that was completed by Anna Gur and all of the Michael Gofield, others, Philip Feng, they did such a fantastic job illustrating that we do need significant denervation in this shaft of the knee in order to provide good and long-term benefit. And I commented that in title, in the same issue of Regional Anesthesia Pain Medicine, I had an editorial titled, "Bigger is Better," or is it? And I think that the bigger is better when it comes to radiofrequency lesioning of the knee. And I'll substantiate this with some of our newer data that we still haven't published, and I think you're going to like it. So obviously the problem is this inferior lateral quadrant. You may partially denervate, you may try to go more anterior, avoiding motor fibers. So we are still not doing this regularly because of obvious danger of denervating motor fibers. I highly recommend you every time when you do denervation using radiofrequency ablation to stimulate. And this study also substantiates this because we learned that most of the time we get positive sensory stimulation more posteriorly in the location that initially we haven't searched for. I can show you large cohort of the data from our place and Dr. McCormick's. No difference much using large cooled RF, same size of the lesion. The only difference was that we had somewhat better outcomes because we did use sensory stimulation. And if you look at the position in any of those pictures, lateral pictures, we are more anterior. More posterior, more advanced electrode. So a little bit about clinical outcomes from the beginning. We had some case series. Pain published first case series using very small 22 gauge needle many years ago. But that eventually evolved into larger case series, randomized prospective studies using conventional radiofrequency and little by little larger probes. The data are decent. More than 50% of the pain reduction, maintaining at 6 months, and then pain starts coming back at 12 months with less and less fewer patients who benefit from the procedure and needs to be repeated. Now, the thought process in our practice and why I was really happy to be the senior corresponding author for our FDA study using a randomized prospective study doing a cooled RF procedure was that I thought that definitely we need to be more detailed when it comes to size of the lesion and positioning of the electrodes. So approximately this is where we were placing our introducers in that study. We published that a while back. Tim Davis led the study. There were quite a few sites. We went through the very rigorous review process. I was corresponding with all of the answers and questions, and although the study only compared cooled RF to steroid injections, it substantiated the data in favor of cooled RF, mainly showing that about 75% of the patients benefit with more than 50% of the pain relief at 6 months, and about 65% of the patients still maintain pain relief at 12 months. That's a really nice time interval for any radiofrequency ablation procedure. So this was a trial design. We had a 6 months crossover. And if you look at those data in crossover, I'm going to, in the next slide, show you those data, going just back to balanced groups. We really had a balanced groups when it comes to even osteoarthritis grade, but also as far as the years of pain, age, and female to male ratio. So those two groups that we compare were really truly nicely randomized. But if you look at this diagram and degrees of the pain scores from about 7.3 down to 3.1, the crossover also provided improved relief of the pain, having better pain relief after they cross over to the radiofrequency ablation arm. The obviously steroid injections did not last that long, and pain relief dissipated at a couple of months after injection. So if you look at the functional capacity and how much more they could do when it comes to range of the knee motion, they really improved significantly from relatively severe functional disability to much wider range. And then not only that, but the patient satisfaction was quite significant and optimistic when it comes to radiofrequency ablation. The second study sort of confirmed what we had when we compare radiofrequency ablation with a large lesion cooled RF with steroids, and this was a study comparing, again, cooled RF with hyaluronic acid. So crossover design, same thing, 12 months. And as you can see, at the time of crossover, improvements were quite significant in these 68 patients when they actually received radiofrequency ablation, and sort of came to the same average improvements in the pain scores of about 3 from about 7. Again, similar data, similar results, maintaining about 60-65% of the patients with more than 50% of the pain relief. Again, very pleased with the data. Now, we wanted to see if in a real world, in our patient population that we treated with a cooled RF with a larger lesion, could we achieve the same results in everyday practice when we had relatively poorer selection of the patients? And in this subgroup of the patients, of 275 of them, we had the patients with average of 3 other sources of the chronic pain. So back pain, sacroiliac joint, headache, fibromyalgia, you name it. Those patients received 2 blocks and then went on to have radiofrequency ablation. So 183 patients returned for a follow-up visit. If you, again, 65% of the patients with more than 50% of the pain relief, very consistent with the data that we were able to achieve from a randomized prospective study. Improvements were profound, again, a little bit higher average pain score for about 8 point something, down to 2 after the block, and about 4 after the radiofrequency ablation. If you look at the long-term outcomes, they were really great. And again, 12 months, we had that subgroup of the patients, 65% of the patients, that we were able to maintain more than 50% of the pain relief, and then we had to repeat the procedure. We were really interested, what happens when we repeat the procedure? And if you look at the left graph here, as you repeat radiofrequency ablation procedure, the average pain scores that was achieved was similar to and not different than from the first time when we provided this radiofrequency ablation. Even more, comparing those patients who had primary osteoarthritis to those who actually had total knee replacement, we couldn't find any difference whatsoever. And it was a good group of the patients, 21 of them that had CRF after the knee replacement. More recently, we said, okay, well, let's look at this subgroup of the patients who received the large lesion cooled RF, and let's see the other group that in our practice were treated. And this was another 170 patients who received conventional radiofrequency ablation using different sizes of electrodes. And this is very interesting. If you look at the conventional RF, improvements in the pain scores after the procedure itself were comparable. We couldn't see much difference. At the first visit, at 4 weeks after the radiofrequency ablation, either use conventional or cooled RF, we got kind of similar results. However, if you look at the improvements afterwards, when it comes to longevity of the pain relief, we only had with traditional RF 2.5 months in average of relief of the pain compared to 11.5, almost 12 months with a CRF. And why? What happened? And how is that possible that we had such a lousy data with the traditional RF? And I'll explain you in a second. So here are the data for 22, 20, 18, 16, and CRF, cooled RF denervation. As you can see, the average pain scores at the beginning for every single of these subgroups was similar. Also pay attention that we didn't have the same number of the patients in each of those groups. But if you look at the 22 gauge, 92 patients, we really didn't get much of the traction there. Mainly because many of them had no response, zero pain relief whatsoever. So in average, we got only about 2.5 months of pain relief. If you look at the 20 and 18, a little bit better. If you look at the 16, much better. And then if you look at the cooled RF, quite prolongation of average pain relief. So I tend to believe that the larger lesion, as I said at the beginning, provides longer pain relief when it comes to knee denervation. With the hip denervation, we are still at observational studies, and we are trying to move forward to something more substantial. Again, same kind of causes of the pain. We actually published also avascular necrosis subgroup of the patients, but mainly osteoarthritis is what we were treating when it comes to this group of the patients. Again, these sensoarticular branches of femoral nerve mainly supply the lateral anterior aspect of the hip, while the kind of key denervation happens medially when it comes to lateral obturator branches. And this is just this quite quick schematic, and I'm going to just show you the, I don't know if I can, okay, here we go. So most of these crossover branches from obturator nerve, we could identify underneath the fluoroscopic landmark, which is called the incisura acetabuli. And the upper part of the anterior ischium, that's what we see the most of the responses when we stimulate sensory. And if we have a few lesions here, the outcome seems to be better. When it comes to femoral nerve, the upper outer corner is where we get the best responses when it comes to sensory stimuli at the very low voltages. So these are then positions of the needles. We first do a low volume diagnostic block in order to determine who are the patients that will go for radiofrequency ablation. And then again, kind of similar location when it comes to radiofrequency ablation. Again, I try to do two lesions, at least two lesions, one at the bottom of this thumb down sign, which is incisura acetabuli, and then anterior ischium. That seems to be providing better and a longer relief of the pain. So initial case reports, and I'm going to go quickly because I have only 5 minutes left. Again, targeted same obturator femoral nerve. We do not target posterior supply because of obviously mixed nerves and motor fibers. 11 case reports and case series suggested that with the conventional RF, you can achieve more than 50% of pain reduction for 3 to 6 months. Small sample size, tedious technique, and risk of the vascular injury. So the technique evolved to avoid vein, artery, and femoral vein, artery, and nerve. By first going lateral, this approach was okay. Unfortunately, there was lots of pain involved in those patients when you try to get underneath the neurovascular bundle. So inferior approach was then advertised, and this is Dr. Menzies who did the first. And basically, he would walk to the anterior aspect of the ischium all the way to the incisura acetabuli. We didn't like that approach either because it was quite painful, so we thought that we should explore anterior approach combining ultrasound to pass by femoral vein from the medial side and with the shortest distance get to the bottom of the incisura acetabuli or anterior ischium. And that's what we did. This was observational study and description of technique. So the technique was basically to place that from the medial aspect to place the electrode at the bottom of the incisura. These are lateral obturator branches, and then we have lateral femoral branches here, and basically passing, using the ultrasound, passing vein, artery, and nerve from medial to lateral. It was quite close. We did the measurements, so the average was, how would I say, close call, about 5 millimeters, but we never had any access to the vascular structure because we were looking what we're doing, coming down, and after now a couple hundred of these, same thing. I still haven't had a single one that I actually penetrated femoral vein. So the first data from the case series were decent. We described technique. We thought that we were able to prolong time interval of the pain relief at the average of about 200 days when it comes to the knee. And then we have, after that, we just published in 2021 a larger case series of 178 of these patients, starting with 204. This is the disposition of these 204 patients. And as you can see, first of all, short-term improvements were profound from about 7 to about less than 3 pain scores in average. But what is more important, we were able in about more than 60 patients to achieve 12 months of more than 50% of the pain relief. I thought this is great, consistent with the knee, easy to achieve, using those several lesions, literally 3 lesions for the whole hip denervation. It takes about 10 minutes. So if you look at the average improvements at 12 months, so it's getting somewhat worse than 6 months, but still maintaining good pain relief, and then after that, procedure needs to be repeated. We really did not look for weaning off the opiates, and that's another chapter that we need to look into, especially if we go with the decent randomized perspective FDA study. So, and then a little bit about shoulder, and I have 2 minutes, so in 2 minutes I can cover some of it. This is credited to Max Aikman and others. There are a couple of folks who are doing this for a very long time. I have a limited experience of about maybe 30 cases that I did. There are 3 nerves to ablate suprascapular, but now much, much more lateral to glenohumeral joint. Any approach is posterior. Seems to be safe. There are no motor fibers. You use your sensory and motor stimulation within that area. Aligning the surfaces is very important in order to have a space that you can actually place that tip of the electrode. Same thing for axillary, and it's below the lateral border of the greater tubercle, just below it, and it's pretty easy to approach it from when it comes to posterior approach. And then obviously, I'm sorry, going back to this, and then lateral pectoral LPN, which is just sitting very conveniently on the coracoid process. So I'm not going to go through the anatomy because I have 30 seconds, but the technique is in development. I think that requires maybe a little bit more of the innervation that we're doing right now. Max is writing the first article. This is how we approach it. You see we aligned glenohumeral joint here, posterior approach. This is one lesion, second lesion is lower down. This is the axillary nerve target, and then obviously the anterior pectoralis. So lateral pectoral nerve. So I'm going to stop here when it comes to, we do not have data to talk about. I had a video that I really wanted to bring, but you can find it on my LinkedIn and on my Instagram. I'll give you my, so video is of one of our colleagues that actually had the innervation with me, and he talks about in details how he went through the procedure and how much functional capacity and range of motion he received with a significant injury to his left shoulder. So just for you. Anyway, so anatomic basis exists. We are very pleased with the initial data. We have strong evidence for the knee denervation. As far as the pilot studies for hip, I think we're going to have to go now to a decent randomized prospective trial. The data are looking good, and I believe that hip is even better target than a knee, more consistent target in my mind. And then larger lesion, bigger is better. Larger lesion seems to be providing better outcomes. And again, you can see that video on my Instagram account as well as the LinkedIn account, and so get a little bit more of his as a medical person and a patient. His sort of overview how that denervation went through. Thank you very much. Thanks.